I'm presenting today with a lot of humility because so many of you in the room are working in the kinds of contexts that I'm talking about and know much more about these relationships than I do. So I'm just here to try and provide a kind of an overarching framework that reflects the work of the Lancet Commission. So this presentation will just kind of guide you through the work of the Commission. So I'm going to begin by situating the report within the current global context, review the report findings, talk about the relevance of the report in particular for the kind of work that you might be doing in fragile and conflict-affected settings, and then just talk about the policy recommendations, learning agenda, and next steps. So this was otherwise known as my pandemic project. It's taken a long time. It's no surprise to all of you that we are living in very troubled times. The world seems increasingly precarious with uncertainty in terms of the path forward politically, economically, and socially. And I found this great visual, and it's no coincidence that it's a suit that's about to push the world over the edge. And again, these are slides that I developed for a broader presentation. This is not going to be of any surprise to any of you. This is data from the Uppsala Conflict Data Program. I'm sorry if I'm in the way. And the Uppsala Conflict Data Program monitors what's called organized violence, which is 3 subsets of conflict. One is state-based, one is non-state, and one-sided violence is targeted violence against civilian populations. So what we've seen in the last year or so is just a dramatic uptick in the level of conflict and violence, largely driven, by Ethiopia, also Ukraine, but we're not seeing a good trajectory in many places around the world. So many complexity scientists have come up with the term polycrisis, which I'm sure all of you have some familiarity with. So a polycrisis is when there is a crisis in multiple systems, economic systems, social systems, political systems. So things like climate change, health issues, COVID, et cetera. When these crises interact, they exacerbate the harm that they produce, but they also really complicate the ability of policymakers to respond to those crises, because our policy responses are so siloed and sectoral. And so people don't really work together much. And I'm sure we've heard examples of this today in terms of the health sector and broader political actors. But what that means is that the mechanisms to be able to work together to address the polycrisis are limited, and the harm that's produced is even greater. So our objectives, we were given a task in the commission. So the commission was formed in 2019, and it was originally started by something called the Swedish Institute for Global Health Transformation, which has since dissolved. So it started off as the Lancet Site Commission, and now it's just the Lancet Commission. We were given the task of exploring the relationships among 3 SDGs. So SDG 3 related to health, 5 related to gender equality, and then SDG 16 related to peace, justice, and strong institutions. So we came up with this research question to guide our work. Can improved health equity and gender equality contribute to more peaceful societies? And if so, how? And so the world really changed from 2019 until we produced the report, but our objectives stayed the same. So we really wanted to bring together people from diverse disciplinary backgrounds to look at this question. Our objective was really broad. This research question is really broad. We did that deliberately because we wanted to establish a conceptual framework, an empirical foundation for these relationships that people like yourselves who are doing work at the case study level could kind of frame their findings within. And we also wanted to contribute to national and global policy development, including the related to the 3 SDGs. So before I go any further, I wanted to just define our terms. Health equity, we use the definition that everyone, regardless of identity or socioeconomic circumstance, should be able to enjoy universal access to quality healthcare services and essential medicines and vaccines. Gender equality, we defined as ensuring that everyone, regardless of gender identity, can develop capabilities, access economic and public sector resources, live in safety and security, and exercise agency. So those are kind of our foundational definitions. When we began this, and I'm very conscious that there's a lot of expertise in this room, so you'll all be aware of the knowledge gaps that exists in this area. So there were a lot of local level studies that were looking, particularly I'm thinking of the Peace Through Health research that was done by WHO and other actors. And there were high level studies, but very little that kind of connected the two together. There were studies on health and conflict, so it was very clear that conflict and organized violence has an incredibly devastating impact on health that lingers for many years after. There was less studies on how improved health could contribute to more peaceful societies. On gender, we also, the relationship or the impact of organized violence on gender equality is also very clear. There had been some political scientists that had done some really interesting work that was at the kind of large N level, which is kind of broad statistical studies that showed a relationship or an association between gender equality and more peaceful societies. But there was very little work that was done to explain how and why that was the case. Those kinds of associations were just presented. And there was very little work that integrated the three together: health and gender and conflict and peace. So that was kind of the state of the field when we started. So we, in terms of our research question, I've already outlined if and how improvements or variation in levels of health, variation in levels of gender, impact on variation in levels of health and peace. So to establish the what, whether or not there was an association between improved health and gender or more peaceful societies, we undertook cross-national statistical analysis. So I had a colleague who's a development economist, and then another colleague who's a political scientist who specializes in quantitative methods do these studies, and they were over long time horizons, so 25 plus years, doing both a cross-sectional and panel statistical analysis, and they explored 3 hypotheses. Basically, and I'll explain this more in a minute, what we decided to do was look at, accept that health and gender and conflict and peace all influenced each other. So we were informed by some work by somebody named Tavneet Suri, who had looked at the relationship between human development and economic growth. And she applied these terms of vicious and virtuous cycles and showed that economic growth and human development, poor economic growth and low human development existed in a vicious cycle. High economic growth and high human development existed in a virtuous cycle. And she did some work that showed that improvements, countries could only transition from the vicious to the virtuous cycle, not just through economic growth, but through human development. So that was her work. So we were a bit inspired by her approach, and we decided to look at this idea of virtuous and vicious cycles, accepting that gender inequality, health inequity, and violence interacted with each other in a vicious cycle, and then gender equality, health equity, and peace operated together in a virtuous cycle. So our 3 hypotheses that we tested were: we called them harmful cycles rather than vicious. Do harmful cycles exist? Do beneficial cycles exist? And then more importantly, do we see a transition from harmful to beneficial cycles if you have a dramatic improvement in health equity and gender equality. So we were really informed by complexity theories that show that in complex systems, it's if you have a dramatic improvement in one variable, it can trigger a reversal of the cycle. So that was the what, and I'll go through our results in a second, but our methods was cross national statistical analysis for the what, the how and why, and the implications for policy. The methods that we used were comprehensive literature reviews, case studies of both countries and processes. So I just have to emphasize that a lot of this work, and I guess this is a good segue into the limitations slide, a lot of this work was really exploratory in nature. We use both quantitative and qualitative approaches, as you call them in political science, plausibility probes. So we were just seeing if these relationships existed to try and establish this empirical foundation for future work. They weren't really, proper statistical causal models, and we didn't do a proper mixed method design. I think that that would be something that future research could do. And we also, I think that it was exploratory in nature, and we did desk studies. I think what's really needed is more implementation research, like the kind that you're all doing. Data limitations, you're all really aware of how limited data is, particularly for the cross national statistical analysis. We used, for gender equality, we used mean years of schooling and adolescent fertility. For health equity, we used infant mortality and life expectancy. Very aware of the limitations of these particular indicators, and we did a very in-depth analysis of all of the indicators that we could find on gender and health that's available on our website. But we needed indicators that were available for a long time period and that had a higher degree of quality across settings. So we're very aware of the limitations of our stats. And then just in terms of our positionality, the research definitely reflects the epistemology and training, particularly the core research group, because the commission was not as active, other members of the commission. So we developed kind of a theory of change, which is encapsulated in this diagram. So if you have harmful cycles of health inequity, gender inequality, and organized violence, we did, if you have improved health equity and improved gender equality, then this can nudge societies from harmful to beneficial cycles over the long term. And I'd just like to emphasize that in terms of the harmful cycles, we are very aware, and we acknowledged in the report that that health and gender are influenced by external factors, external economic, social, political, geopolitical factors. And so we're very aware that the historical injustices have led to communities and countries finding themselves in harmful cycles. And we didn't want to put too much, how can I put this? We're very aware of the limitations, I guess, or the ask of health workers and communities themselves to try and undertake these processes to nudge themselves out of conflict. But we did find some interesting results, so I'll let. So in terms of the cross-national statistical analysis, no surprise, we found extensive support for the existence of harmful cycles. Beneficial cycles, we found support for their existence with a caveat of ceiling effects. So one of the things that the people doing the statistical analysis found is that life expectancy can only improve so much, infant mortality can only go down so much, and so these kinds of limitations, you can easily see the harmful cycles. It's harder to always see the beneficial cycles. And it's explained more in the report. We did find support for transition out of harmful cycles through some sequencing analysis. And we found stronger support for health leading the transition out of harmful and into beneficial cycles. But we found strong support for health and gender in terms of sustaining those beneficial cycles. So this, in terms of how and why these associations existed, we adopted a framework that had been developed that looked at human rights, the application of global human rights norms, and it's by somebody named Catherine Sickink and Thomas Rees. And how and why, how improvements in health equity and gender equality may lead to more peaceful societies, or do lead to more peaceful societies. We looked at both the principles and mechanisms of health equity and gender equality as being really important. One of the things that we argue in the report is that although these processes are very contentious, particularly in terms of gender equality, building a social acceptance or taken for granted status on the principles of health equity and gender equality that we talked about, or that we outlined as our definitions, involves the advocacy for and adoption of these key principles that make us look at each other differently. So there's something about those processes that are very powerful and catalytic. And the other thing is that neither health equity or gender equality can be achieved through rhetoric alone. So things like democratization or other forms of, other areas that have been researched in terms of their linkage to more peaceful societies, it's very easy to use just rhetoric or to just have an election and not really have that kind of deep-rooted kind of accountability of democratic systems. You can't fake gender equality and health equity. These indicators show something and they're meaningful. And so there are these mechanisms that we outline in the report that are important for actually ensuring those improvements in health equity and gender equality. So work that I did with Sally a few years ago, we looked at the bricks and mortar approach. And so the idea of both gender equality and health equity is that you need to have laws that ensure and recognize the basic rights of men and women. You need the laws that ensure, some degree of access to healthcare services. You also need things like the delivery of health services, the building blocks of health services. For gender equality, you need education, infrastructure, access to technologies, access to resources, et cetera. So these principles and mechanisms, once they're put in place, they are catalytic because they transform human capabilities. We adopted a human capabilities approach. And through the impact on human capabilities, you have economic effects, social effects, and political effects. So it's well documented, the improvement in human capital and inclusive economic growth that is achieved particularly through things like access to reproductive health care. Social effects, stronger social capital, particularly the kind of, there's a bunch of different forms of social capital, and we looked at both, we did reviews of both linking social capital and bridging social capital. So bridging social capital is when there's strong links between different groups within society, and linking is the relationship between advocacy groups or civil society groups and government. And so that advocacy that is part of the improvement of health equity and gender equality is really important in terms of fostering that social capital and transform social norms in terms of a declined acceptance for aggression, The political effects, this has been written about, the improved degree of a social contract, and higher levels of trust and a better quality of government. So particularly for gender equality, there's really interesting studies that show a relationship between improved gender equality and decreased corruption, et cetera. So these studies were all very it was a comprehensive review of the literature. And then we looked at some specific processes like women in peace negotiations, et cetera. In terms of the implication for the health sector and what this means, we talked about health systems or social systems. So we made a really strong argument in the report that health systems and health services really need to reflect upon the fact that gender norms are reflected in the way that health services are delivered. We looked at, to kind of examine this point further, we looked at the gender blind nature of COVID-19 responses, including a review of pandemic modeling, which seemed to guide a lot of policy direction. Sexual exploitation in humanitarian contexts, and the experiences of women as well as sexual and gender minorities in terms of their willingness to access healthcare services. And then we also looked at the power of the health sector to transform norms and promote equality. A lot of the work that you have already done in the previous iterations of Rebuild, we drew upon that, particularly the power of close to community providers. So the importance of the health sector taking on and accepting their role in promoting gender equality, maybe of particular relevance for the work you're doing. We looked at the humanitarian sector and how completely gender blind their responses are, despite having adopted a lot of gender-based analysis. There's a very thick OCHA handbook on gender. But when you start to kind of really dig into if and how that those gender norms are integrated, it's very, very patchy. So anybody that has worked in humanitarian settings know that a lot of the gender-based analysis is so complicated, even for people with some expertise in gender. And the handbook itself is incredibly thick. And so people are very busy, resource constrained, and you look at this and how do you even begin to implement it into your day-to-day work? And so we are making an argument that the humanitarian community needs to really integrate gender equality by extending the principle of humanity to explicitly talk about gender equality, embrace their responsibility to advance gender equality outcomes, and then confront abuses of power in humanitarian settings. And we came up with a definition of gender equal humanitarian action. And again, like all of this report, it's just, this is a starting point to get the conversation rolling. And we hope that people will take these definitions and improve on them. We also adopted benchmarks for gender equal humanitarian action, getting back to the point that it's so challenging for people that are not gender experts to be able to know what it would look like, what a gender equal humanitarian system would look like. So we came up with benchmarks in governance and leadership, financing, health information, human resources, and health services. Again, just as a suggestive starting point. So these are all outlined in the report. The other thing that I think is really important, that we have a chapter or a section of the report that talks about, was originally entitled The Promise and the Perils. So there is an extremely promising foundation upon which initiatives for health equity and gender equality can build. There's a good baseline of kind of global norms on gender, global norms on health, lots of inspirational stories to draw from in terms of the power of networks, what we call the international exchange of ideas and how important that can be. But I think we can't, there's also these emerging opportunities, which are really important to highlight. The power of digital technologies, for example. We often, a lot of the narrative about digital technologies, particularly related to gender, is one of it's kind of fear, right? That it's a tool for increased harassment and violence. And we really wanted to put the emphasis on the positive impact that digital technologies can provide if they're used properly. But I think more importantly, we documented some of what we call the missteps of gender equality and health equity interventions in the past. So, there's many more examples than just these three, but the instrumentalization of both health equity and gender equality for the foreign policy interests of external actors, rather than for the well-being of the people in the community in which these interventions are being undertaken. Imitation projects. So this was there's a really interesting book about Eastern Europe called The Light That Failed. And so I borrowed this term from this book, and it talked about the efforts to build kind of liberal institutions. And I think the health sector in Eastern Europe would be one of these, where the impetus was on just taking models that worked elsewhere and planting them in a context and just assuming that they would naturally take root and be successful. And so this was a really problematic misstep, I think, because as we know, health systems are social systems and they reflect the way that societies and cultures think about health and how they work together. So, an example I use from my own continent is the difference between Canada and the United States in the healthcare system. The United States is a very entrepreneurial, private sector economy. Canada is a more public sector economy, and so you have these dramatic differences that are reflected in our health systems. And then another misstep, we call it the superheroine fallacy, this idea that you can elevate women to leadership positions without changing the structure in which the structural conditions which impact on gender equality. So 4 main messages came out from our report. Again, just a starting point, that improvements in health equity and gender equality have this unique and powerful ability over the long term to contribute to peace. So this isn't a short-term project. It's not going to be a year or 2 years, but that process of building systems of gender equality and health equity. To realize this promise, we really focus on what we call inside-out processes. So gender equality and health equity need to be led by communities tailored to context. Nothing new for any of you. The health sector must embrace, advocate for, and advance health equity and gender equality. And then health equity and gender equality must form an integral component of peace building and other national and global processes. Recommendations, we have kind of these 4 categories with very specific implementation pathways for each. Communities and contexts should shape and drive gender equality. Health responses for gender equality initiatives to advance health equity and gender equality should support openness, inclusivity, and accountability. So some of the things that you were talking about in terms of the Syrian example here, accountability to communities. National and global agendas for development and conflict should incorporate health and gender. So again, detailed implementation pathways. We also included a learning agenda where we kind of divided what we thought was needed in terms of future research and approaches into kind of 3 categories. Definitely the need for diversity of perspectives. Partners, that this really should be led or by countries and researchers from the global south. Methods, you need both the kind of empirical research that we did and more critical and interpretivist approaches. They complement each other, they don't clash with each other. and the incredible power of research networks to be able to work together. And the power of networks is particularly if they're interdisciplinary. Approaches, again, this need to foster interdisciplinarity, implementation research, and the critical importance of sharing data and assessments. One of the things that drives me crazy is how much data is available and how little access we have to it, and also gender assessments. Lots of donors and other organizations do these assessments and they're never shared. And then themes, so knowledge gaps in terms of the need for conflict analysis to be integrated into our understanding of these processes, and particularly in health, and why and how you can ensure that health services are embraced rather than not embraced in conflict settings, and then knowledge gaps around community-driven action. So what is new about this? I think, again, it's just a first step, but health equity and gender equality we show as independent and interacting variables that shape violence and peace. So this is new, particularly at a cross-national level. I think even our conceptual framework is useful for how to think about these relationships, that recognizing that they all interact with each other. The theory of change, that improvements in health and gender can nudge from harmful to beneficial. And then our research and policy agenda, which is kind of recognizes both the successes but also the missteps of the past. I think that is it. Yeah, so in terms of next steps, I think we all see this commission report as a beginning and not an end. There's much more research that's needed, particularly the kind of research that you are all doing. So the need for, both kind of research, but also implementation, how you can implement these kinds of findings. So I think, yeah, so for more information, there's two websites. There's the Lancet landing page, and then there's a commission website. And we will be doing policy briefs and posting them on the website. So yeah, thank you very much.